around gender-based violence that's happening right now during the COVID-19. Hi, everyone. My name is Sarah Martin. I'm your moderator for the session today. And I'll be joined by three great panelists from around the world who I'm going to allow to introduce themselves at that time. But before we start, I just wanted to give a little background information for all of you who are joining us today. Before the outbreak began, we knew that gender-based violence was a global problem. The statistics that we have say that 1 in 3 women experience some form of gender-based violence during their lifetime. We know that during humanitarian responses and humanitarian crises like natural disasters and wars, that these numbers go up because the protective factors that keep women and girls safe disappear during these times. But what we're learning now is even during a global pandemic like COVID-19, we're seeing an increase in violence. All around the world, activists that work with women and girls and work to prevent and respond to gender-based violence have been reporting in what we're calling the shadow pandemic, the dark side of the pandemic, and how it's disproportionately impacting women and girls. We're seeing intimate partner violence or domestic violence increase and also intensify. We're seeing an uptake wherever there are actual helplines for women experiencing domestic violence. They're being overrun by calls. Websites are getting record numbers of hits. For example, in Tunisia, they noted that the number of calls just in the first months of the crisis increased by 5-fold. The United Kingdom, the UK, saw a 25% increase on their national domestic violence hotlines and a 150% increase on the website that had resources for them. On top of that, we're seeing a new form of sexual violence that's happening, which is online harassment. So as we've moved ourselves into the online world, we're having online cyberbullying, a new phenomenon called Zoom bombing, where people will overtake a webinar, always targeted towards sessions that have women and girls or people of color, and show pornographic images or insult or try to disrupt in any way. Where they keep statistics around violence online, we saw in Pennsylvania, just in the month of April, they saw a 700% increase in reports on violence online, and they saw the same month the year before. Australia saw an increase of over 50% in some of their online chat rooms that they were working. So that's just in the everyday world. And what we're going to look at today is, as humanitarian professionals and people who are working on gender-based violence around the world, there's even more difficulties that are impacting us all. Again, my name is Sarah Martin. I'm representing Gender Associations, a Berlin-based consulting firm where we work on women, peace, and security, and also gender-based violence globally. But I'm calling in from Greece because I also have fled the COVID that's happening in Berlin right now. And all of my colleagues here, I'm going to allow them now, I'm going to turn over to them to talk a little bit more about, to introduce themselves and to talk a little bit more about where they are, what they're seeing, where they're at. Lena, I'll ask you first. So what are you seeing right now, where you are, and tell us where you are.
Thanks so much, Sarah. My name is Lena Abarafi. I'm the executive director of the Arab Institute for Women that is based out of the Lebanese American University. It is an institute that is both academic and activist, covering the 22 Arab states. I am now calling in from New York. And what I'm seeing across the region and in New York as well is we knew there was going to be an increase in GBV as a result of the pandemic. We were already aware that this happens in contexts of insecurity, in crises. I also spent about 2 decades working in humanitarian emergencies on GBV. So we've had this experience time and time again. The evidence is there. And yet with every single emergency, it's as if we have a brand new discovery that GBV has suddenly sprung up and everybody behaves as if they were surprised and couldn't have anticipated it. And unfortunately, we who work in this field could have quite easily predicted. In a place like Lebanon, for instance, where resources are already stretched and scant, what we're seeing is women and girls not having their needs met at all, unable to access services and support, increase in intimate partner violence, which is an unfortunate global trend, even here in New York, actually, one thing that I should highlight is in New York, we subscribe to a text messaging service that is an update on COVID and how the pandemic is doing and what we need to do. And in the first 4 or 5 weeks, the message was very consistent several times a day. And it was shelter in place, stay safe, stay at home. And we knew that home is not necessarily safe for many women. And so we thought, well, it's obvious that women's voices weren't considered and women's perspectives weren't taken on board in this kind of messaging. And by the 6th week, there was a dramatic turn. All of a sudden, the messaging shifted. And it was, we understand that home is not necessarily safe for you. And if you're at risk or if you're in a situation of intimate partner violence, call this number, do this and this. All to say that all around the world, we still are ill prepared to deal with the kind of phenomenon and the unfortunate patterns that we see over and over again.
Thanks, Lena. Now I'd like to ask Mohammed, phoning in from Afghanistan. Please introduce yourself and tell us what you're seeing there in Afghanistan.
Hi, hello everyone. I'm Mohammed Farouk, mental health supervisor from MSF Afghanistan. And recently I'm in Afghanistan and supporting the MSF project here with the gender-based violence. So, as all we know, we had a lot of barriers for the survivors seeking for help or for support. So we have global barriers for these survivors, like blame, judgment, shame, stigma, everything. And these things become more worse when the COVID started with this pandemic. As Alina said, home is not safe for everyone. And I have to mention that even in this my region, also we have some survivors, male survivors, young boys. So a lot of things changed with the COVID-19, and a lot of medical setup changed with the COVID-19. And we had some cases before reaching out to have a support here. But with starting COVID-19 here, so they can't, because a lot of the governmental system has changed, the medical system has changed, more people focusing just on COVID and ignoring the SGB services in other places. As MSF, we are trying to support them as much as possible and make it easier for the survivors to have access to our facility for asking help, and we can give them quality care.
Thanks so much, Mohammed. Now I'd like to ask Maria to tell us how things are going and what you're seeing in Kenya.
Hi, everyone. I'm Maria Ofwona. I'm a protection officer at Highest Refugee Trust of Kenya. It's an organization that works with refugees from South Sudan, Congo, the Great Lakes region, that's Congo, Burundi, Rwanda, Ethiopia, Eritrea, Somali. So as an organization, we work with different persons with specific needs, women at risk, chronically ill, but especially SGBV survivors, and also LGBTQ individuals. So we have had, we operate a gender-based violence information management system, and the numbers that we recorded of the incidences that were happening before COVID were rather high, but during the COVID situation, we noticed that reports were not coming in as consistently as they had before. This is also due to the fact that individuals were now isolated. There was a lockdown. We are also experiencing something similar to a second wave of COVID, because the numbers have, as when the lockdown was lifted some months ago in Kenya, the numbers are getting higher and higher. So we are foreseeing a possible second lockdown. And some of the challenges and some of the things that we are seeing here in Kenya is livelihoods are still being affected, because there's something similar to, we have currently curfew. So we still see for the young women who are SGBV survivors who have been maybe selling their wares in the streets are not able to work to the end. And then we are seeing arrests and detention, and not just sexual and gender-based violence, but violence in general. We're also seeing evictions from housing, where the young women and children end up going to camp outside the agency offices, that is the different organizations that we work with. We are seeing limited access to medical and healthcare. Right now, it's a little bit better, but still there's that fear of contracting the COVID virus that we see, and people are not able to pay for the services, to get the medical services, because their livelihood has been affected. We're also seeing a cutoff from social support. This has been mitigated by the teleworking system that we have, but where we do counseling services over telephone, but we still have survivors of violence, the women who are not able to contact us over the phone because sometimes the perpetrators are people within their own households. So there's lack of familial support, where we have individuals who live in Kenya, they have left their family in the country of origin or in a different area of Kenya, and so they're not able to talk to their family members because they don't have the resources to be able to do this. We've also seen an increase in cases of especially domestic and intimate partner violence because of the isolation and the lockdown. So individuals are not able to fully come out of this, because our offices are also not open 100%. So we are still working teleworking. And finally, we have seen children not going to school and not able to get the food that they need to get the 3 square meals a day. So we have individuals who are going hungry and women who are struggling. So that's just a summary of generally what we're seeing in Kenya.
Thanks so much, Maria. I'm seeing some similarities between all of the different regions that we're talking about right now, particularly with the struggles to be able to provide support. I wonder if you could reflect a little bit for us on how people are trying to change the way that we respond to survivors in order to work in this new kind of environment, and how that's impacting the barriers to survivors. You mentioned a bit about it, Maria. Lena, what are you seeing in the Middle East?
Well, the challenge is that it was already very difficult for survivors to access any services and support. They're very few. They're always underfunded and understaffed, and there's a lot of stigma around this. And so when we're talking about a situation that is amplifying all of that, where some of the services are being repurposed and kind of reallocated for COVID response rather than for GBV, it becomes even more difficult. So there are hotlines and people are using them. But again, how much the call actually leads to an effective response that meets a survivor's needs is hard to tell. Just last week, actually, there was a report released by the ICJ, the International Commission of Jurists, about Lebanon, talking about the lack of justice. There are still some weak links that we face, and people are flagging them, but because the resources are so stretched and everything is so compromised, and in a place like Lebanon, with the recent explosion as well, there's just no human or financial capacity to be able to meet the needs of the population. So this report was talking specifically about the justice sector and the lack of investigation and prosecution of GBV and no accountability. And that's something that's not new, but at least we're talking about it. So I feel like the knowledge, the conversation, the anger that will eventually lead to action, but without the adequate resources, the attention needs to also bring the funding and bring the support that will enable us to make a difference, because otherwise we're just howling into the void and we won't be able to get anything done.
Yeah, I hear you there. For sure, this has been, I feel like, a very much discussed event, but what's actually happening on the ground? Mohammed, maybe you could tell us a little bit more about how MSF in Afghanistan has been working on gender-based violence and what you've changed around now that COVID's happening. I know it's an extremely complex country to work on this topic, and it's really amazing that you're there right now actually able to provide support for survivors. So could you tell us more about what's happening there?
So I want to start with the good thing we did in this project. So we start this program with a lot of difficulties because of the sensitivity of topic and the culture and other barriers we have here as MSF. So, and also MSF, the only organization in this area I am living, have this program to support SGBV survivors. And we couldn't even talk about SV or GBV before, but now we can talk in our organization here in our hospital and talk with the staff and support them how to identify the patients and survivors and ask them for support. So it was a great achievement for us. So beside that, we had challenges with starting the COVID because SGBV is already sensitive here. So it's always underlined and nobody paying attention outside of our organizations. So with the COVID, the other crisis start, it's completely ignored outside of the organization. As MSF, we are trying to make the access to hospital for the service as much as possible. So with the COVID, we had to unfortunately decrease the number of patients. We are seeing decrease the number of criteria we are admitting the patient, decrease the number of triage system or changes in triage system. So we feel that maybe we will lose some cases. They cannot come and cannot access to the hospital. So we are working on that area. Unfortunately, we missed some cases, but we have now a little bit good system. We have trained people in the emergency room, so they can identify the patients by the symptoms and by their behavior, and we can support them much better and more.
It looks like Sarah has just gone off for a second. The connection on a Greek island maybe is questionable. Maria, do you want to take it forward and continue and build on what Mohammed was saying about his experience?
Yes, of course. Okay. So for us, I think, for us, what we are doing and how we are supporting SGBV survivors currently, we are majorly purely teleworking. As the COVID numbers had started reducing, we tried to find ways and to work within our organization to see whether we could go and start going back to doing in-person activities, but that has not worked out. So currently we are using hotlines. We also have hotlines. We have our own highest hotline, and we work with our partners. That is UNHCR is one of them. And our other partners in the Urban Refugee Protection Network. Sorry, Sarah. I'm just moving forward with what you had asked. And we have the working groups. We hold virtual working groups. That's the Gender-Based Violence Working Group. As HIAS, we co-chair the Gender-Based Violence Working Group, the Child Protection Working Group as well, where we now discuss we flag the very urgent SGBV cases and incidences that have happened. We get these referrals from the community members themselves. We have community workers who are part of the refugee community, and they're based in each of our offices. We have our three higher site offices. So they flag these cases to us, and then we're able to discuss them. And then they're very influential in terms of getting the first-hand response when it comes to gender-based violence. Then we now do the referrals to our partners. That's the Nairobi Women's Hospital that works with gender-based violence. We have MSF as well, but here in Kenya that works with survivors of gender-based violence. And then we have bulk texting. We have bulk texting and information, education, and communication materials, where we highlight all the cases and whatever information we need to communicate out. We have that, we review it, then we send it out to the community for them to get this message firsthand. Then we have panels. What we have is a psychosocial panel that we pick cases, assess them. If they're vulnerable, they meet the criteria for vulnerability. We do give financial assistance for a period of time, let's say 3 months. We had the gender-based violence community caregivers program, where we trained caregivers who are also survivors of gender-based violence for them to take care of other survivors. But that program, we couldn't implement it anymore because of the social distancing and the fact that the survivors now people can't stay together in too many in a particular house. So we have that, then we give them financial assistance, and then they're able to go into the community and live. And so those are just the few things that we are doing as to support individuals with who are survivors of gender-based violence. Then just to mention, we have particular programs, the UNTF, United Nations Trust Fund, and Norwegian Church Aid projects that work to change the mindset of the engaging men in accountable practices. That has also been very beneficial, so that we're able to have that conversation. As had been mentioned earlier, we have that conversation on gender-based violence, and now we actively engage the men who majority are usually the perpetrators of violence. In brief, thank you.
Thanks, Maria. I hope you can all hear me all right now with my challenges with the internet. Thanks, Lena, for leaping in, as always. So I wanted to ask you all, one of the things that I found when this crisis started was, first of all, there was an explosion of webinars all over the internet, and suddenly everything shifted to working online, which was challenging, I think, for a lot of the places we work because of internet connectivity and being able to connect on there. What have you been seeing that's low tech?
I think we've lost Sarah again. Sarah, are you there?
Yeah, I think so.
Okay, so, well, I think we've missed part of her question, but we're going to pick up where she's left off. So with the explosion of webinars, what are we seeing that is low tech? I think this has been a really interesting experience in terms of how we engage with each other, how we engage other people in these conversations. In a way, it's enabled us to have events like this that reach a much broader audience than otherwise would have in person. If we're all gathered in Berlin, it would have been much more limiting. But, from my perspective, I think we tend to forget that not everybody has access. And if we bring it back to GBV, we speak kind of overwhelmingly of survivors as one big category, but for the Arab region, for instance, there are categories of survivors who are fundamentally left behind, regardless of whatever kind of services and support, whether it's low or high tech. And I'm speaking about refugee populations, for instance, and people who are internally displaced. We've got a massive problem in Lebanon with nearly 2 million Syrian refugees who already were living in pretty dire conditions, but now, as a result of COVID, are less able to access any kind of support, less able to get the kind of help they need. Another vulnerable group for us in the Arab region is female migrant domestic workers. And the treatment of this community from various nationalities has always been a violation of human rights and completely unacceptable. But in these types of situations where vulnerabilities are amplified and insecurities that are magnified and GBV increases, everything just gets so much worse. And so these populations that are already suffering are completely completely stranded without any type of care and support, because we just don't have enough to meet the need. So, what survivors are we prioritizing, and who are we leaving behind? I think that's one of the big questions that I struggle with. Maria, you mentioned working with LGBT populations and taking into account other vulnerable groups. Maybe tell us a little bit about that, and then Mohammed as well. And, we'll hope that Sarah comes back. And I know she's got loads of questions for the three of us, but I don't doubt that we all have so many stories to share anyway. So building from that, who is left behind for you?
Okay, thank you, Lena, for that question. I concur with what you've just said, especially in remote parts, because we are talking about bulk messaging. Even as we say bulk messaging, even as we say we have hotlines that survivors are ideally able to access, but we know very well that a large number of women who need these services are not able to, they don't have the resources, they don't have the airtime to be able to call their counselors in case they need some psychological relief. They don't have the internet. We're talking about trainings now that everything is moving and becoming virtual. So we have trainings online. You want to continue to train and to capacity build the community. And then you realize that as you're mobilizing survivors, they don't have the airtime and they don't have the accessibility to the internet to be able to work. So the silver lining in that is that for the LGBT community especially, majority come from Uganda. And as we compare with individuals from the other nationalities, for the Ugandans, they're relatively younger and they're much more tech savvy. So they usually have community-based organizations. A large number of community-based organizations right now in Nairobi are for the LGBT-led CBOs, and they're much better when it comes to having internet connectivity and having bundles for internet and having airtime. So sometimes we also use, because we say the resources are within the community itself. The community itself is a resource in itself. So we say if sometimes we need to reach out to survivors because we have LBQ women, lesbian, bisexual, and queer women who have gone through some form of SGBV. So we have the communication is sent out through we now use the community-based organizations to pass over that information. If we do need to share some very vital information and we know that some other communities, maybe the Somali community in Eastleigh area in Nairobi, are not able to get that information, we use our LGBT-led CBOs to reach out to maybe a community worker who works in the Eastleigh office. Then they're able to pass over that information. So you're right when you say, I do feel that people are left out. There are survivors that are left out when it comes to accessing the services online and doing teleworking. There are people who are normally left out.
Well, I'm back. I understand from my friends WhatsApping me on the corner that you guys are managing just great without me. So I'm happy to hear that. It just shows what amazing professionals you all are. So I don't want to interrupt you and let the conversation continue to flow. But I did see there were a couple of questions in the chat room. So if I can ask one, and then maybe you all can answer to that. So somebody was speaking about online trainings or trainings for non-medical field staff on how to respond to GBV. Maybe you guys can respond a little bit more about how more people can support and to care for survivors.
I'll take this one. I'll start at least. For the Arab region, I think it's always been informal networks, your friends and family and neighbors, and the kind of sisterhood and solidarity. And the more that we are receptive to that and we know how to handle those things, and the more we speak to each other about it, the better equipped we'll be to support each other. In the end, it's like we default to the lowest tech, simplest, longest running, and most obvious source of support, and that is the people closest to us that we trust. In the end, no matter what kind of shelters and safe spaces and counseling and psychosocial support and police and legal and all sorts of things we might have on the menu, whether they work or not, our first outlet, our first recourse, our first source of comfort is going to be the people we trust. So as long as those people are as much as they can be prepared, aware, and not dismissive of it, we tend to take a risk in doing that, speaking to people who aren't trained to respond appropriately, to say, well, that's okay, this happens, and, don't worry, and keep going, and stick it out, whatever types of messages that you may get that can do more harm than good. I think with the conversations that we have and the increased awareness, especially among younger generations, actually, which I think is very promising, I see that people are more aware that this is a problem, that this is a crime, that this is violence, it's a violation of human rights, it's a violation of bodily integrity, and that they want to speak out against it, and they want to protect themselves and protect each other. So there is more anger and there is more clarity on what is right and wrong. And so we're better equipped then to help each other on an individual kind of informal level, as we seem to have done since the beginning of time.
Good points. And almost in every emergency, the first responders are the people who are right there, right? So for when it comes to gender-based violence, it's your sister, your friend, a person that you trust in the community, someone that you trust with your secrets. Which leads me to think about, with so many people trying to use mobile phones and technology to answer this, and this question was coming up in the chat. Kenya, we've got a lot of mobile phones. People do a lot of things with their mobiles in Kenya. Afghanistan, I'm not sure that women have much access to mobile phones. I haven't been there in a couple of years. So what are you seeing in your regions of how to reach women who don't have access to mobiles? Mohammed, maybe you could go first, then Maria, then Lena.
Yeah, I wanted to just answer this question because Lena asked the same question before. So we were talking about the online support, but I think the online support is not working in Afghanistan because, as you mentioned before, very limited women, girls, or people have access to the phone, and even most of them don't know or don't have access to the internet support. So as MSF, we're trying to make a support system for the survivors. So when we have a survivor here, we ask them for a contact number so we can have a follow-up on them. But unfortunately, most of the time, they don't have any contact number, or they have the partner contact number. So it's difficult to have another person contact number to support the survivor. And we give them our contact number whenever they need support. They can call us, but they don't have any phone to call us. And when we want to contact them, the number we have from the survivors, when somebody answers the phone, we don't know who is that, so we cannot support them. And it's not safe for them to talk from home in front of the partner or from other people abusing them. So it's very difficult here we have a hotline or we have an online support for the survivors. And most of the time for the SGBV survivors, we need more physical support than the online, because most of them need medical treatment, care, and face-to-face psychosocial support to get released. And for the Afghanistan, people are not so familiar with the technology, and the phone and access online system is not very supportive for the survivors here.
Maria, what about in Kenya? How are things working with the mobile phones, and how are you reaching non-mobile phone users there? Because I know access to credit to use your phone is an issue for many of the people we're talking about.
Mm-hmm. Okay, so thank you for that. For us, our focus that has really made matters much better is the community structures that we have. The community structures have been the most beneficial. By that, I mean the community-based organizations, the community leaders that we have, and the community workers. So as I had mentioned earlier, the community workers are individuals who come from the refugee community already, and then they work with the organization. So we have had, for example, if we need to pass messages to these are community workers who know they even know where all individuals within their area live. So if we need to pass information, or the client or beneficiary needs to access a particular service, and they feel that they're not comfortable doing it or calling when they're in their house, we have had examples where some survivors have gone to a community worker who works with the organization and been able to report, or use the phone of the community worker to be able to reach out to a social worker at the highest office. Then through that, we have known that this individual lady needs services. So there's that. And then there's community leaders also, who are also very well versed with the areas of jurisdiction at which they are placed. And through these three areas, community workers, community leaders, and community-based organizations, we've been able to access these survivors who may not have the reach of getting the telephone or the bulk messaging. And then another method has been at the point we put information and education and materials at our offices. So we paste them maybe outside the gate of the office, just to pass information, just in case a survivor needs to, will pass through the office thinking that maybe the office is open. They'll be able to see the poster, and it's translated in different languages. So they're able to see that. Or if I need GBV services, here's where I go. It's translated in Swahili, it's translated in English, and all the refugee community languages. So they're able to see now from that. And another method is the WhatsApp groups. Kenya is very, very advanced when it comes to telephones and messaging. So there's WhatsApp groups. There's no specific one for GBV survivors because of the confidentiality involved, but there are WhatsApp groups where someone is able to notify, a community worker is able to notify a higher staff member that there's a particular lady who you really need to talk to. She's extremely vulnerable. Just that. Then we pick up now. We talk to our counselors, then they pick up from where that community worker has referred. So that has worked well with us, the community structures. Thank you.
Have we lost Sarah again to the wilds of the Greek Isles? Well, there's one thing that I've noticed actually as a result of this new kind of crisis that we're experiencing. As we've all had to adapt and all go online, I think perpetrators have been just as creative and have adapted quickly and have advanced to new forms of violence. It's as if there is not one single space that is left without any form of violence or discrimination or oppression. And what has happened, I don't know if anyone else has experienced this, is on platforms like Zoom and other, and now I have 3 or 4 experiences of this. Somebody will enter the space and hijack all of the screens. I think there's a proper tech term for this. I don't know it. But what they will do is show disturbing images, pornographic images, or write messages on the screen. So everybody's screen suddenly goes black. And they will flash these images one after the other, and you can't touch anything and you can't do anything, and you are powerless to stop it. And they are anti-women messages, and they are inciting violence, and they are vulgar. And it is shocking to see. The first time it happened to me, I thought, I must have done something, and it was, I jumped back because it was so much violence and vitriol that we were all shaken. I mean, it really disrupted the entire conversation. And then when we all were able to regain control of our screens, people were shaken and disturbed. And the point of that is that there is continued effort to oppress, to dominate, to show violence, to exert control, to use and abuse power, even in this new form, and I worry there is no safe space. I worry that the increase in online violence or cyber violence, like I know for Lebanon, 180% increase in cyber harassment or whatever kinds of things. I mean, that's astronomical. And you do not feel safe even behind a screen. And I worry about how that is going to continue to manifest as this becomes the way that we normally work. I worry about young girls being more susceptible to this kind of thing because this isn't just the way we work, it's the way we connect socially as well. Without these screens and these devices and these modes of communication, we have no way to reach each other anymore. So we've opened ourselves up, but we also have increased our risk. So I'm wondering if you both have noticed any new forms of violence that have come up as a result of this, and how we're all struggling to cope with them. Mohammed, do you want to start for Afghanistan?
Yeah. So it's a very famous issue here about the phone harassment or online harassment for the woman especially. So we have a lot of survivors. So, or some female, they are having access to the phone number, or they can use a phone, but they have to change their numbers very quickly because they're being hacked. The phone numbers, their social media will hack, and the images or the photos being hacked and receiving threatening by phone, by social media. If you don't, your photo, your mail, your voice will be posted on social media. So it's a very famous harassment here in Afghanistan, and most of the women who are having access to phone and internet access, they are suffering from. So also it's difficult for us to access them by phone because it's very huge. The female lost the trust to give number even for the support for people.
Exactly. It's really frightening. Actually, Maria, do you want to add from your perspective new forms and how we're coping?
Yes, but I don't have this in terms of the cyber harassment and Zoom porn. We've not experienced that. Maybe I can just say that at what we have experienced is maybe the perpetrators, as you had mentioned earlier, the perpetrators are also very smart, and they are in their moment of abuse. They really find creative ways to be able to continue like torturing and like creating such a big psychological issue to the survivors. We have had instances where perpetrators pose as community workers because some of the individuals in the community don't know who the community workers are. Not all refugees know exactly who the highest community workers is. So maybe a perpetrator might pose as and then take advantage of the survivor. They say maybe they'll offer some services. They say maybe they'll refer them to a certain organization and take them there. Then through that, maybe when people are walking in the street, then maybe the survivors the individuals end up being raped, end up being abused, being beaten, their things stolen from them. So the posing as the impersonation is what we have seen, especially in using of the telephones. But yeah, I think that's what I need to add for that.
I think you're absolutely right. And both of you, you've highlighted those issues that you feel like there is no safe space and there is no safe person. And if you're not able to trust any of these platforms or these ways to reach people or the people who are supposedly there to help, I think this kind of the psychological damage, as you were saying, that this is going to do to all of us and the broken trust in any kind of services and support or whatever systems emerge, in our post-COVID life, are going to be very hard to rebuild. It is not as if the pandemic will end and we will go back to business as it was. We will not suddenly be in 2019 all over again. We will have to start from the very basics and rebuild trust and rebuild people's confidence in disclosing and in seeking support and in trusting people who are there to help them, and people respecting the duty of care. I mean, it is a setback that I think we're going to feel for a very, very long time. There is a question actually about engaging men. And maybe I'll pose it to both of you. And I think we can answer it in two parts, perhaps. It is how men are being engaged as part of the response and support, but also perhaps male survivors. And if there is any kind of special concern there that is happening in your respective countries. So, Mohammed, Maria.
So do you want me to start first?
Sure, and take any one of those and pass it on, and we'll keep going.
Okay, so for the survivors as a mental health team, when we want to support them, so sometimes we feel like we have to engage especially for the IPV cases, engage the partner or the husband for the counseling, for the support system, and find a way how we can support them. But most of the time it looks difficult because the client, the survivor, doesn't want her words to be transferred to the husband, because sometimes it even gets more worse when we talk about the husband about the violence, because the husband, the abuser or the partner, doesn't want the survivor to share it with someone. So if you want to highlight it with the abuser or the partner inside home, it sometimes gets even worse for the survivors. We don't do it too much because it gets a little bit difficult for the survivors. And for the young males, so we have survivors, male survivor, young boys most of the time, and even children. So access to the healthcare is a little bit easier for the male here than woman, because they are, as a male, they have more priority in the community and in this culture. So they will take them as soon as possible to the healthcare services or the legal support. But for the woman, it's difficult because it's always shame for the culture and for this community to take a woman to the health or care or ask for the support.
Maria, go ahead. Over to you.
Okay. So for us as HIAS, we had, when it comes to male SGBV survivors, as I've heard and as it's seen even on a large scale, especially in Kenya, is that we have very limited information and very limited reports of males who are survivors of gender-based violence. So as HIAS, at a certain point, we run SGBV support groups, specifically male SGBV support groups. The quorum was very difficult to meet because the survivors just will not, based also on culture. So we had individuals who they come from the Great Lakes region, Congo, for example, where they use rape for men as a weapon of war as well, and to emasculate the men. And so we have these many men who might have gone through SGBV, but they'll never disclose, not just because of the implication of what it does to their masculinity. It's also because of the culture. What will it do? What will be the implication of them saying that they are SGBV survivors? So, and also one of the myths that abounds is an individual doesn't want to be labeled as gay. So we have had instances where SGBV survivors have gone to seek medical assistance. Maybe they have had incontinence, because we were running a program to support specific male SGBV survivors at Nairobi Women's Hospital to access aftercare. Maybe they got incontinence and hemorrhoids as well. And now, once they get to the hospital and they talk to a healthcare worker who maybe does not have a deep understanding of how a male would be raped, so they don't want to be told that they are gay. So because of that, and also because they are men, and because culture is a big issue, and the social status will go down, so there's no reports. We have very, very few who normally report, but once we do get the male SGBV survivors, we try our best to refer them to hospitals and healthcare facilities that we have had trainings with. At least some of the staff members are able to know that there's male GBV survivors who might not identify within the LGBTQ spectrum. So that has helped, and of course, sharing information on people should know that male SGBV survivors are there, and they might not necessarily be LGBT, but they are there and they need the services just as much as the women need the services.
Do we have Sarah? I don't think we can hear her.
Yeah.
Okay.
I think she's talking, but we cannot hear her.
Okay. Well, I know the question, there's so many interesting things to talk about. And I think this group is coming with such rich and diverse experience. But perhaps let's talk about, in this kind of context, how caregivers are usually women. I think that's a global kind of reality. And how are they dealing with all of this, the increased burden, addressing GBV, experiencing it? Very often those who are galvanized into this work are survivors themselves, who probably have never dealt with that kind of trauma, plus, working from home, plus childcare, plus, dealing with those who are sick. How are women in your countries and communities dealing with this increased burden? Maria, shall we let you start?
Okay. Yeah. So for the women I'd mentioned that before the COVID situation and everything locked down, we had a community caregiving program. We had like gender-based violence caregiving program where we trained 15 caregivers. These were SGBV survivors as well, but they there were especially old incidences where they had already gone through counseling, the group counseling, individual counseling, for them to be psychologically prepared to be able to take care of another GBV survivor without bringing back the harm to themselves and without feeling that the fresh wounds, like to bring the wounds and become more fresh. So these SGBV caregivers were women. Yes, majority, in fact, all of them were women. It's very challenging for them to take care of other survivors, not only just SGBV, also during the COVID period. There's SGBV survivors, there's the COVID period, and how they have been able to deal with it. Some of them, we have really educated them and psychoeducated them in terms of reaching out for psychological first aid and psychological care, really being counseled. Because again, as a caregiver, we had to give them some financial assistance for them to take care of the survivor. So maybe the caregiver would get a certain amount of money and the survivor would also get a certain amount of money just for like an incentive for these individuals to be able to take care of each other and have to support each other through that period. But it's really a challenge for women caregivers. But I must say that I think COVID has also, people are becoming very resilient in a way. Let's just say I'm seeing women are really resilient. They really stretch to be able to take care. It's like it's brought a human face, not just about how people were isolated and people could keep to themselves and stay in their own houses. But now the women were very willing to continue remaining with, if it was allowed, continue remaining with the survivors. And even after the 3 months of assistance that we're giving, the financial assistance, they stayed with the survivors. They help each other out, support each other. As long as we have chiefs of particular areas, they need to know that these individuals are living together in this house and they're not related. So after that, they've somehow managed to get the counseling, get the support that they need. If it's financial assistance, they've been able to get the financial assistance that they need and then get the medical healthcare through our networks as agencies. We're able to make sure that once we get information that this lady caregiver needs assistance in terms of supporting the SGBV survivor, we ensure that both of them or the whole family at least is able to be cushioned from COVID and also to be able to help the caregiver to be able to try and survive. So psychologically, they've been able to manage.
Mohammed, how does it look in Afghanistan?
So in our organization, we have the more or less equal number of caregivers, male and female. So we have male trained people to be a caregiver for the male survivors, and we have the female caregivers trained very in a good way to support the survivors. So I'm happy that we have a strong team here, national and international staff both. So doing whatever we can do for the survivors. And sometimes it looks difficult for some women caregivers to support other women because sometimes they are coming from the same problem. Like Maria mentioned, they themselves were a victim or a survivor of the IPV or other violence. So sometimes it's hard for the caregivers to support other victims because for all the psychological effects already they have. But I think they are strong enough now, and they are doing their best to support the survivors. And we are trying to cover the all program here. Like we have a very huge hospital. Every day, more than 500 patients coming to the ER emergency room, and a lot of we have in IPD. So we are trying to cover this all patients and see them as much as possible to identify the cases and support them. And most of the time we are covering it by the mental health support because when it comes to the mental health, people open up, disclose, and we can identify the cases. And for the male, I think this is our success that we have very good male caregivers for the male survivors. And we have made this system for the male too, so they can have access to the healthcare and support system here.
What's interesting to note is I think it's a global trend that, as I said, women are the majority in informal caregiving roles and in formal caregiving roles as well. And the pandemic is disproportionately affecting women who are on the front lines as caregivers, as nurses, women who are in the healthcare field. There are some statistics, for instance, in Spain, that 75% of the healthcare workers who contracted COVID are women. 70% for Italy, and in the US and probably other places, there are statistics about that. So they are really putting themselves at risk in personal and professional ways to be able to provide the kind of support that that people need as a response to this pandemic, which is really troubling. That women are always out there as part of the social safety net, the first to respond. They know who needs help, how to help them, who to reach the people who are the most in need. So, this again is just a new manifestation of that trend. What I want to ask is a question that we've gotten from the audience. That is, isn't it time that we start looking at existing community protection mechanisms against GBV and so on? And isn't it time to give more ownership to women-led local CSOs who are active in this area? Isn't it time? Well, yes, indeed. It is not only time, it is well past time. And I think that we have seen time and again that the most effective responses are the local ones, the ones that are embedded in the sociocultural context, the ones who are trusted and respected by the communities, the ones who have been doing the work long before any kind of international response or support arrived, and they will continue long after we are all gone. So absolutely, I loved the phrasing of this question because isn't it time? Indeed. So maybe tell us from your local perspectives, is that the type of response that you're seeing? So what is the localization perspective, if you will? Maria.
Yes, I also like the phrasing. It's way past the time when we are supposed to really look at ensuring that the community is empowered and has the structures are really strengthened, because we talk about accountability to affected populations, we talk about sustainability. In most of the projects that we run, we usually are giving the sustainability. How sustainable do we think these projects that we are running are? I think that I agree fully that we should be able to go to the community structures, because these are the first points of contact. Before some of these individuals reach the organization, they meet their fellow refugees in our context, and they meet their fellow women and the fellow community workers who are within the refugee community. And so they need to, we empower them, we give them capacity, we do trainings for them, we have forums, we have dialogues, we have the 16 days of activism, we talk about GBV, we maybe put information, communication and education materials, we might do all this. But at the end of the day, if we don't focus, we don't align our programs and our projects to have part of them to focus on ensuring that they have psychological first aid skills to meet these SGBV survivors. They have some basic counseling skills to be able to talk to the survivors before an organization can take up that case. If they don't have the capacity to be able to start community-based organizations where they can start sourcing for their own funding in the internet, where the Ugandan community are very good with that, where they source for their own funding and then go to GoFundMe in Facebook. They use social media very well in terms of funding for sourcing for funding. So if they don't have this capacity and we don't purposely and intentionally train them and tell them that this is what you need to do, try and think about that. In any case, funding is going down. In our context, funding is going down in the humanitarian space. In terms of financial assistance, it's going down. So we have to move away from individuals just depending on agencies. And we also, as Kenya, we implement the encampment policy, where refugees ideally are supposed to live in the camp and not in the urban area. But we do have about 70,000 who live in the urban area, and they choose to live in the urban area and they say they are going to be able to survive. So it's our responsibility also to be able to help them, to be able to have community networks and strengthen their own networks so that they're able to survive longer. Even after an agency shuts down, they pick up from where it left off, however basic it is, then they can grow from there. So I think, yes, 100%.
You know, we talk about localization and the localization agenda as a new development buzzword, as if also this is a discovery that we've made, and isn't it a wonderful idea? But, you know, I would ask all of us, where is the money? it is our job, those who are claiming to help, those who are coming with international organizations, UN agencies or international NGOs or donors or whatever, to provide the tools and the resources for these local community-based organizations to do the work that needs doing. Otherwise, we can write very nice reports about localization all day, but they will be rendered meaningless unless we put our money where our mouth is. And Maria, you said it, funding is going down, the talk is up and the funding is down. And it's always been the same problem with anything gender-based violence, whether emergency or not. The rhetoric never matches the reality. We are hearing so much about it. We make very grandiose promises and we are given pennies to be able to implement. And it is impossible to ever meet the need in any effective way. It is impossible to be accountable to the people that we are trying to help if we do not have the resources. And I would ask, anybody who is listening, who is coming from a donor agency, to really hold those agencies accountable and say, let's stop talking about these kinds of things, about the response, about prevention, about localization, about whatever we think we're doing for gender-based violence, which is the longest running crime of all time, and ask, where is the money? Let's measure the dollars, because every time we do it, we fall dramatically, embarrassingly, shamefully short. So, Mohammed, if you have anything to add to that about localization and the challenges of that.
Yeah. So if I want to talk about the protection in this local area or by our local services, it's very poor. So we can say we don't have nothing. So MSF is a medical organization, and we are trying our best to support the survivors medically, best quality care for the survivors. But we all know that the survivor needs more support, just not medical support or psychological support. They need much more support, like social support. They need the legal support. They need support system in the country, in the local area. So MSF, or we trying to advocate it with other actors. And also what we did to make it more local support for the people, we are training the national staff here to empower them to how to respond to the survivors and empower them how to deal with the survivors in the future. And also we are trying to, and also we did, to train other actors or other NGOs staff about the GBV, about the response, and training them to how they can refer the survivors to our organization so we can give the medical support and psychological support.
I think there's so many challenges that we're facing, and I believe that we've got maybe another 5 minutes left. I know that Sarah, who is still present with us in some ways, had wanted to bring up the idea of very kind of old, traditional, simple, low-tech approaches that we're using to try to reach survivors. And we talked about handouts and flyers, and using radio and drama and theater and art and people hanging bed sheets on balconies, all kinds of things that are happening that are maybe low-tech, old-fashioned ways that we might have used long ago in terms of accessing GBV survivors. Do you have any evidence of that, or anecdotes or experiences from your countries? Maria?
Apologies. Sorry, can you repeat the last part?
Oh, yes. Oh, and also, Sarah is saying, as I'm now the voice of Sarah, that she has shared resources in the chat for more information, but she had wanted to ask what things have emerged that are old-fashioned and low-tech, like using radio to disseminate messages, or using flyers or posters, or other types of things that we might have done pre-internet, let's say, to be able to reach survivors. Have there been any, is there a revival, do you think, of those types of ways to reach people?
Okay, for us, I think there's been a revival, but to a small degree. For us, it has been mostly the flyers and the posters. Those have come in handy. We have really gone back old school. It's sometimes you say old is gold, but yeah. So using the flyers and the paperwork and posting all over the place, and someone just has to come to one location to look at it and see and read. It's interesting because it takes us almost back to the medieval times, but it's been very beneficial actually, because that's information has been passed, and the refugees have not had any complaint. They have gotten the information that they need without having to access, having to someone else to tell them or to go through the look for airtime bundles, blah blah blah. So yeah, I think in terms of that, though, that's what we have been using.
So
Mohammed,
for Afghanistan.
Yes, please.
So I think, Afghanistan is not a safe place for living at all. We have armed conflict going on, and also because of the cultural barriers, we have a lot of challenges. So we cannot go easily to the community and talk about the SGBV, about the GBV or IPV. So it's very difficult. We are not on that level yet, so to reach out to the community. And I was surprised when COVID started. We had a lot of messages on the radio, on the TV show, on the phone area. Like we had the same system here, like stay home, stay safe, but we never had this system to talk about the GBV, SGBV, or other kind of violence here, because it's very sensitive here. So it's very difficult for us to reach it out very easily and talk in the community, even with this old-fashioned system.
I think so many interesting points have come up, but now just to kind of wind down and to give our audience something to kind of marinate in, something to process, what's our takeaway? Is there an action that we'd like from our audience? Can we ask people to do something? What would be your one call to action or your one priority for the way forward, or something that is really going to make an immediate difference? I'll let Maria go, Mohammed. I'll see if Sarah has anything to add, and I'll put in a few words before we close.
Thank you, Lina. So for me, I think I would just say 2 words. I would call for action is advocacy, and okay, I've already said the 2 words, but no, advocacy and dialogue. In terms of SGBV, more advocacy in terms of resources, as Lina had mentioned. If we hold ourselves responsible and hold ourselves accountable, if we require that these community-based organizations and community structures need to be strengthened, let's help out. Let's now channel the money away from individuals being too dependent on handouts to taking the money, now channeling it to helping them to start off to do their activities, and then they can build from there when everything picks up. So advocacy in terms of that, and dialogue, continuous dialogue on all these forms of sexual and gender-based violence to all the communities, including children, to SGBV, to women who have been affected, children, men who have been affected by who have been raped and who have been sodomized, and boys who have been sodomized, and also to populations, minority populations, like for example the LGBT community, and the other marginalized populations, the ones that the ethnic populations that are not reached so much. So a lot of advocacy and a lot of dialogue. You can never talk enough, but just even in images, even in posters, as long as someone keeps seeing it and someone keeps hearing the messages, then maybe things will change eventually. Thank you.
Absolutely. Mohammed, your big takeaway for this audience.
I just want everyone to be a speaker for the SGBV. Just be a helper for survivors and keep going supporting people. If they know anyone suffering in silence, just help them and refer them for the area they know they can have a support.
Absolutely. Sarah wants us to share the following, that she wants the audience to educate themselves on GBV and then educate a friend, male or female. And she's asking, are men talking to men about these kinds of things? And I think that's a really interesting question that we can all reflect on, because actually I too would like to see men speaking to each other. You know, I will firmly insist that not all men are perpetrators. There are many, many, many who could be allies and supporters and could be much stronger, much more outspoken in preventing GBV, but maybe they don't know how to have these conversations, or they lack the language to do it. And I would love to see that happen. And I'd love to see it happen with younger men and even adolescent boys as well. I think that's the most effective way to prevent this from happening, is to get that message from your own peer group and your own community, rather than from anyone from the outside. So I think that's a great point and a great question for Sarah. I think my key takeaway, priority message for the audience, it goes back to funding. Again, I want to see unrestricted, long-term, operational money that goes directly to women's organizations. Enough with the conditions and the short term and the quick fix and the donor-driven priorities and all of that. And I can say this as somebody who switched sides, so to speak. I spent most of my career with international agencies and then moved into the so-called local partner. And that is the institute that I now run. And the difference in terms of our abilities to determine the course of our own funding and to designate the priorities that we know best has been a constant battle. So please, money directly to women's organizations, and let us decide what to do with it, because nobody knows better than the people who are working on the ground. And with that,
Exactly.
Thank you so much. I know, I mean, we're all nodding our heads, because enough already with these kinds of conversations. And I'm not the first to say it, I'm the millionth to say it, but I think we just need to do it. With that, I will thank the audience for bearing with us through switching moderators, technical difficulties, and life on a Greek island. For Sarah, and for letting us graciously extend 11 minutes past the closing. You all stuck with us. Thank you to the awesome panel. I love your respective countries. I've been to both. And thank you very much to the Humanitarian Congress Berlin. Continue a great conversation and a wonderful session, and fight on. Goodbye.